This conference will now be recorded.
So, hello everybody. Welcome to our Labor Day 2023 session of the High Risk Recurrent and Advanced Prostate Cancer Group. I'm moderating tonight. We got a smallish group, but a lot of people to get through and one new gent. Before we start, I just want to remind all of you who are listening, as well as those who will be listening to the recording, as well as those of you here. If you haven't contributed a recommendation to great nonprofits, please do. We need, I think it's 10. We usually do this in January or February, but it escaped us this year. We need 10 recommendations from throughout AnCan. So there will be people hopefully making recommendations from other groups. Last time when I checked this morning, I think we had 3 or 4. So if you have not already given us a recommendation, you can go to our homepage and you can click on testimonials at the top of the homepage, and you can write whatever you want, good or bad. I guess I have to encourage you to write whatever you want, but it will help us because then we'll get our great nonprofit seal for 2023. I think that'll be our fourth in a row. So I just wanted to say that, and especially for the people who are listening to the recordings and they get a benefit from them, we would much appreciate.
For people that did that last year, should we do it again this year?
I don't know. I don't think so. So we try not to ask. We try not to do that, but I don't know what the actual rules are. If I was running great nonprofits, I would say you can't do that, but I don't know. So I'll have to defer to my great nonprofits managers. Bill Franklin is the one who usually runs all of that. All right. So Jeff G, who was referred by Dr. Jack, who's in the house. Jeff, you're new, and usually what we do with new people is we run you through a little questionnaire, and then we try and find out if you have any questions for us and if we have any questions for you. So if that's okay by you, we'll start. How old are you, Jeff?
72.
Okay. And where do you live?
In Westchester County, New York.
Aha. Okay. And what year were you first diagnosed?
This year.
Okay.
July 3rd.
Okay. I guess I should ask you, in deference to our co-moderator who is just moving to Westchester County, if I'm not mistaken, what part of Westchester County?
Town called Chappaqua.
Ah, yes. And Len, where are you going to be?
I'll be your neighbor in Mount Kisco.
My wife works in Kisco.
Okay. Well,
Very nice.
that's you're going to be very lucky to have Len as a. Believe me, you're going to be very lucky to have Len as a neighbor. So you were just diagnosed. What was your Gleason score and your PSA at diagnosis, Jeff?
Gleason 9, and my PSA was 9.82.
And was that a 4+5 or a 5+4?
4+5.
Okay. And where was that diagnosis made?
In Westchester County, I had a fusion biopsy in June. I got the
Okay, and
results January 3rd.
what led to the fusion biopsy? Were you symptomatic? Was there an issue, or was it just routine?
Well, I had BPH for a number of years. I had a big
Hmm.
prostate, 75 grams. I was on Proscar and Flomax. And sometime in January, I started to feel a unusual sensation, a deep urethral ache, a
Hmm.
coldness, a sensation I had never felt before. I went to a urologist. He told me I had prostatitis. He put me on Levaquin for a month. When I was there, I had asked, could you just feel my prostate? He declined. He said he didn't want to spread the infection. So I took the Levaquin, went back, and I wasn't feeling much better. Uh, I asked for a MRI. I had one 2 years ago. I had a PIRAD score of 2
Hmm.
back 2 years ago. And he said, no, you don't need an MRI. I said, well, what if this is prostate cancer? He said, you know what? You have a 4K score of 6 and you had a PIRAD of 2. This is not cancer. So I recommend you get a resume procedure. So I underwent a resume procedure
Hmm.
in March. Wasn't feeling much better, maybe a little. And 3 months later, I demanded another MRI, and my PIRAD was 5. And then very quickly, he agreed to do the fusion biopsy, which I said had a Gleason 9.
Okay. And is this a community urologist, or are you at one of the centers of excellence satellites?
This is actually, I was a professor of medicine at Einstein, and this was one of my residents who I trained 20 years ago, and somebody I knew and have faith in.
I had a feeling, Dr. Jeff. I had a feeling. I was waiting for the right time to ask that question. So were you a surgical prof? Were you
No,
a
I'm
surgical
an
professor,
internist.
or
I'm an internist.
oh, you're an internist? Okay. All right. We'll join the club. As you know, we got Dr. Jack in here and we got Dr. John in here. We could use an internist, because we stretched Dr. Jack and we stretched Dr. John, and they've forgotten most of the internal method. Well, no, Dr. John's pretty good, I have to say. Dr. John's pretty good. Wouldn't you say, Jack, that Dr. John's good? He is, isn't he?
Dr. John's good. Dr. John's good.
Okay. All right, Dr. Jeff. So this was one of your residents from Einstein.
Right?
Oh my gosh.
No,
I had
the guy who's taking care of me now is a resident who I helped train when I was at Montefiore. The urologist who previous uh, is not somebody I trained, but the doctor I'm with now is.
Oh, the doctor you are with now. Boy, I have an old girlfriend who was you probably trained her too. I'll have to send you that in the chat window.
All right.
Um, by the way, the chat window is those little boxes in the top right, and there's nothing in there right now, but somebody will put something in, and I'll send you a message when I get a moment or in the next meeting and see if you train this lady that I went out with for a long time.
Sure.
Okay. Um, let's see. So right now, why don't you tell us where you're at? I mean, we know you got a 4+5. We know that you're a Pirates 5. Have they done any scans of any
Yeah, I
sort?
had before anything treatment started, I had a PET scan, PSMA scan,
Mm-hmm.
which fortunately was negative for
Good.
spread outside of the prostatic base, but I do have spread to the right seminal vesicle.
Okay.
So I've
And
gotten, oh, go ahead.
no, you go ahead. I was going to ask you what they're recommending.
So I've gotten Firmagon. Tomorrow I get my third series of shots. Obviously, the first one was 2 shots, then a month later, 1, and tomorrow is the third installment. Because I have osteoporosis, I'm going to be getting Prolia
Yep.
injection tomorrow.
Yep.
And about 2.5 weeks ago, I started on Zytiga and prednisone.
Right. Okay. Did you get a baseline testosterone level before your first
Yes,
Firmagon?
it was 450, and after the first shot, a month later, it was undetectable.
Great. Okay. That's really good that that it went down so quickly. That's a good sign. And B, it's great that you was smart enough to get that baseline, because sometimes it's not always done. Um, I think the big issue, and you may have discussed this, is whether you are going to consider any radiation.
Starts on October 2nd.
Okay, and what are you doing?
Well, it's going to be 48 installments every weekday for 48 days. So October 2 to December 7th, the external beam, and in mid September, I'm going to have those fiduciary markers put in to the prostate.
So, and where are you doing this?
With this provider at ARC.
ARC stands for?
I'm having a senior moment. It's one of these big
Yeah.
radiation centers.
You know, I would really encourage you to get a second opinion, because 48 sessions today is really, you can cut that down a lot. So Mac Roach at UCSF, who we know very well, and in full disclosure, he was my doc. What he does now is 2 sessions of SBRT to the gland, and then he follows that up with 20 to 25 sessions across the pelvic girdle. And that's fairly standard in most of the centers of excellence. I mean, if they've got SBRT equipment, there's no reason to go through all those trips for the IMRT. The other way to do it, which a lot of people do, and I've known people with a lot of success that have gone this route, is to do brachytherapy as the boost. So you can do either HDR, either 1 or 2 sessions. It depends on the protocol where you're going, but it can be 1 session. If not, it's 2. Or they can put in seeds, which is what I had. And this is many, many, many years ago, but I had seeds plus IMRT. And I just hate to see men go through 48 sessions when you could probably be done in about half that time.
Well, I'm going to be speaking to Michael Zalewski as soon as he's firmly established at NYU. He left Sloan Kettering.
What?
Yes,
really?
He did. Yep.
Oh my gosh, when was that?
The past few weeks.
Oh my gosh. There's a turn up for the books. Yeah, I mean, I would say that's yeah, definitely go talk with Zalewski. And I don't think Zalewski would be doing 48 sessions. He
No,
does.
he's not. Unfortunately, though, I have two friends with Gleason 9s over the last 5 years, both of whom I referred to Sloan Kettering from my practice days,
Yep.
and they had short courses like every other day for 10 days, and both of them developed bladder cancer with that shortened treatments. So, but I'm going to speak to him. I've already spoken to him uh, a couple of times. Fortunately for me, his father was a professor of mine,
Oh, right.
and so I knew his
Well,
dad, and I'll speak to him again. I just wanted him to settle down at
sure.
NYU before I called him
Sure.
again.
Look, you're already on the hormone therapy. So don't rush into these 48 treatments. And Zalewski is great. You can tell him he knows Mac real well. And say to ask him, what do you think of the Mac protocol with 2 SBRTs and the pelvic girdle? See what he says about that, because that's
Right.
only 2 intense sessions, and then the rest of it is the IMRT. Now Mac used to do 4 sessions, but he now figures that it can be done in 2 sessions plus the IMRT across the pelvic girdle. Let me have you had any genetic testing?
Yes, I did. I had a prostate panel, and there were no mutations.
Okay.
BRCA tests, and I think it was 18 mutations, all
Okay.
not present.
Okay. And that was germline, right? Not somatic.
Germ, yes.
Yeah. So I am going to. Well, we've got a bunch of guys who are taking abiraterone. Very familiar. So the other thing I'd like to throw out for you to consider is, if you can get it with your insurance, is switching to Orgovyx rather than the Firmagon shot, only because what we're seeing, especially with guys who are a little older, is if they're able to come off the therapy, which you may be able to, then the testosterone seems to be returning much quicker, which is really a positive thing. How long have they discussed with you remaining on the therapy?
Well, initially the discussion was for the Firmagon was 2 years.
Right. Yeah, and that's sensible. It's probably 18, somewhere between 18 and 28 is the right number, and it just depends how you're doing. But we are seeing guys recovering much quicker when they're on the pill rather than the shot. But I'm going to
Well, the
open it up.
Firmagon is no fun, as everybody knows.
No, it
Those
isn't.
those injections into your abdomen leave you feeling like you got hit by a 2x4 for a
Yeah,
good 3 days. So
yeah, absolutely.
Where do you talk to Len? Where do you talk to Len Sierra, your neighbor? He'll tell you about the wild ride that is. I don't know how many do you have, 13 or 15 or something, Len?
Yeah, I believe I did it for 15 months, and it got to a point where I was having fevers and flu-like symptoms after the shot. So, I switched to Lupron, but Rick's suggestion is even better because Orgovyx is also a direct antagonist. So it, as he said, your T levels will recover much quicker.
So Any questions for us about the abiraterone, managing the side effects? Anything that we might have missed that you want to ask us about? Anything on your mind, Dr. Jeff?
Well, I guess the two worst side effects I'm having, which I'm pretty sure everybody has, is fatigue and sweats, flashes,
Mm-hmm.
hot
Mm-hmm.
flashes.
Mm-hmm.
Those are, I would say, the two worst ones that I'm experiencing.
Who wants to jump in on that one with some ideas for Dr. Jeff?
Okay, I'll go.
Go ahead.
Okay, Dr. Jeff. Anyway, I was on the pills for 5 years. Exercise is the key. Aerobic exercise. Plus, it sounds strange because you are fatigued. So, and with the hardest part shall be, and with to get outside and to do some thing. Anyway, I do some kind of bicycle. Very, very simple rides, and it really helps me a heck of a lot.
So,
Yeah, I'm trying to walk 2 miles a day, but some days I'm so pooped I can't. But when I can, I'm giving it a shot. It is and a little weightlifting too for my
right.
muscles and bones.
So, I mean, the key that we've found from our experience, and I did 28 months of hormone therapy, so I can relate. Um, you've got to get that heart rate up. Doesn't matter from the aerobic side of it. You've
Yeah.
got to get that heart rate up into your 80% plus region for a good 15 to 20 minutes. That's where you're going to feel the difference, because you can go out, you can walk around, you can putz around in the garden, what have you. If you don't get that heart rate up and keep it up there, at your level, at your age, it's got to be around 120 or so. So you've got to get it up to that level for a good 10 minutes to really feel the benefit. What's going to happen, I suspect, is that yes, you'll feel tired. Yes, you may need to come home and have a nap, but you're going to feel so much better for the rest of the day. And some of the other guys here can talk to that. That's what we find probably to be the best remedy for the fatigue. The other issue that we will discuss with you the Ember wristbands, which everybody has. So you'll see some people holding up their wrists to the screen, and these regulate. Yeah, I'm scared to say anything when I'm talking to such a fine professorial internist, but I forget the name of the nerve that's in the wrist. But Dr. John, you want to explain how these embers work?
Tell you the truth, I don't think the mechanism of action is really fully understood. But they become warm or cold, and the body attempts to adapt to them by reducing your hot flashes. And the guys in this group have had really good luck since the Ember has been developed. So if the hot flashes are enough to really bug you, that's the nicest and least invasive way of dealing with it, I think.
It gives my wife good company.
Yes.
Yeah.
Well, your wife can get an Ember too. They come in black
Yeah,
and pink.
yeah,
So
we have our flashes together when we can do
yeah,
it in tandem.
that's exactly right. So I'll put the name. It's Ember Labs, and somebody I'm sure will put the link in the chat window for you.
Thank
I
you.
can't do it, but we strongly recommend you look at them. We get a discount, but it's no more of a discount that you could get if you order one on Amazon or Costco. Costco has them. and they have nighttime settings, and they work probably for 80% of the guys. There are some guys that they don't work for. So if there's anybody on here who has one and it didn't work for them and they want to sell it on, now's your chance. Okay. Oh, Harry, it didn't work. Speak up, Harry.
No, I didn't find it to be very helpful. My hot flashes would come out on so quickly that I think the device wasn't quick enough in reacting, maybe. I don't know. It just, I didn't seem to get much satisfaction from it.
Okay. Well, if
So
you
somebody
want to
wants it, I still have it.
okay, well, if you want to move it on, send a chat message to Dr. Jeff, and you can make a deal. We only ask for 10% here at.
There you go.
No, it's free. I'll just, no problem.
What do they cost now? Is it still 300 or so?
Yeah, it's still 300. And actually, we've been in contact with them. We tried to see if they would do a sponsorship with us this year. We don't do any branded sponsorships here, unless it's a product where there is no alternative, as is theirs. And we do promote their product because we think it works for a lot of the guys. And actually, what they are going to do is they're going to give us some of the older models to give away. We're still trying to work out the logistics on those. But I also know from people like Jeff Marchi that the older models are nowhere near as good as the newer models. So,
I wouldn't say that. I wouldn't
No?
say that. No. In fact, a lot of times, so at times I've used both at once, and the older one works great still. But you have to be aware that you have to be able to understand when your body starts to feel a hot flash coming on. You got to hit that button the moment you start feeling it, or you are going to get that hot flash. It's very critical to hit it right away. And it may come on a little bit too. I mean, I have a fan right next to me a lot of the time, and because it'll come on and I'll get a little warm, but it'll go away. But it really suppresses them. And in fact, I was at a memorial 2 weeks ago, and I brought both bands with me, and I turned them on 36 times, and the place was hot. I had no problems at all with the heat. I didn't sweat. I mean, it was pretty incredible to have be in a spot where normally I would be hot, and I was not hot at all.
Okay. Anybody else have any suggestions, advice for Dr. Jeff in terms of handling these the fatigue and the?
One more.
Go ahead, Jimmy.
I always have to put in the pitch for the weightlifting. As a doctor, I don't have to tell you that extreme testosterone suppression, what it does to muscles. And the big driver of the fatigue, it's not my opinion. There's a lot of data on this. Big driver of the fatigue is muscle loss. And despite whether that is specifically true or not, as we get older, we're losing muscle mass anyway. And if we allow ourselves to get further and further behind when we're on ADT as we get older, then we're setting ourselves up for all kinds of problems. So part of getting old is lifting weights, in my opinion, and part of ADT is lifting weights for sure. And you mentioned that you were doing it, and I would encourage you to do that just as much as cardiovascular. I think they're both equally important.
Right.
Jeff, this is Peter. Besides Zalewski, are you consulting with a specialist medical oncologist yet with prostate cancer?
The person I've been dealing with is a radiation oncologist who said if I felt that I wanted to speak to a medical oncologist, she would set that up.
You probably want to, and you probably want someone, since you're in the New York area, there's some really top people that's prostate oncology, that's their specialty. And it's with a Gleason 9, I mean, you're probably in for a long ride here, and you'll be switching drugs and this and that. You probably want somebody on your team who really is up to speed and up to date on the latest and greatest.
Yeah, and you know, I don't know anyone at NYU, although we know Stacy Loeb really well, and be happy to ask her. But I think, you know, one really good option is Dana Rathkopf at MSKCC, who we've worked with for years and years and years. As you probably know, Mike Morris has also just left Memorial Sloan Kettering to go down to NIH. We really like Dana Rathkopf. She's a really good option, just compassionate, kind, understanding, very smart. And of course, Dr. Jack knows the personnel there pretty well. But, you know, talk to it before you tell us who your RADONC is suggesting, and we can give you some feedback, and then, you know, we can throw in some other names. Dr. Jack, is there anything you'd like to say to your buddy?
I'm glad you came, Jeff. I think what you shared has been very useful to all of us, and I think you're going to get a great deal out of this group, and I'm happy to see you here.
Thanks. Has anybody had any use for or positive results from incorporating tofu into the diet in terms of the flashes?
The tofu and soy have been the subject of a lot of attention, and there's a great many guys out there who wouldn't go anywhere near a soybean because they're afraid that it will emasculate them or something like that. I think overall it's great to have soy in your diet if you're in our situation, but I don't recall ever seeing a specific effect on hot flashes.
I've been eating tofu for God knows how many years, and I still had all the hot flashes.
Yeah,
Well, at
there's a
least it
study.
tastes good.
Another option you should consider, I get a Depo-Provera shot every 3 to 4 months. I get 10 or 15 hot flashes a day. If I don't get that, if I do get that shot, it drops them down to 2 or 3. Now, I know Rick doesn't like Depo-Provera. I've been taking those shots for over 4 years, and they really do cut the hot flashes to very minimal. But, you know, if you're not getting that many a day, then you don't need that.
Right.
There are other other hormone solutions as well.
Harry, you wanted to say something?
No, I was just going to comment that I believe there's a study out there about soy and hot flashes, and you know, it's not overwhelmingly positive. And I tried quite a bit, and I didn't really notice. I mean, I have soy just because it's good once in a while, but I didn't notice any improvement in my hot flashes with that.
Thanks.
Now,
I would just
you know
like
what?
to.
Go ahead, Jeff.
I gotta just say one thing before we move on, which is that if you find yourself resenting that urologist for delaying your diagnosis so long and wondering whether you would have had, extra prostatic extension of your cancer or high-grade cancer if it had been diagnosed earlier, and if this starts bugging you, bring it up in group sometime too, because a number of us have feelings like that.
Yeah, what bothers me is I'd be done with my radiation already.
Well, if we can get that radiation down from 48 to 25 treatments plus, then at least we'll halve the time. But then you'll have to consider whether it would be 48, whether you'd be done with the 48 versus the 25. Anyway, very last comment goes to Alan, and because we got a lot of guys to get through tonight. So
yeah, real quickly, Jeff, I'll just throw out there, and may not be fair, but I was on Orgovyx. My medical oncologist first talked about shots, and he said, "Well, we've got this other pill," and it was wonderful for me. Now I wasn't on it long, no hot flashes. I didn't notice a huge drop. There was a drop in my strength, but I didn't notice it, and so that was wonderful for me.
Right.
Thanks.
But then you're an exception. You're sitting there. You're older than Dr. Jeff, and you're climbing these climbing walls and going out mountaineering all the time. So we think that you may have some of those Superman genes in you, Mr.
Well,
Babcock.
my heartbeat when I'm climbing, my heartbeat is like 140. When you're up on a tough climb, yeah, your heartbeat's up there, and I'm out, 2 times a week minimum. So yeah, I realize that, and that's why I'm almost hesitant to speak up. But there you go.
Okay.
Better
All right,
avoid
well,
kryptonite, Alan.
he probably takes kryptonite pills on the side. I don't know. But anyway, Jeff, we got your back. Keep coming back. Keep coming to these groups. We also have another really great group that Jack will tell you about called Men Speaking Freely. We got a meeting this week on Thursday for that group, and in that group we talk about everything except treatment. And Dr. John is one of the moderators. Our other moderator isn't here tonight, but it's a really good group, and the guys enjoy it, and you can laugh, you can cry, but it may be worthwhile, and Jack will fill you in on that. All right, I'm moving along because we've got a lot of people, and since we don't see him that often, I'm going to go to Mark Baldridge first. We see him in Men Speaking Freely, but we don't see him so often in this group. So Mark, why don't you bring the guys up to date and tell us what's on your mind?
Sure. Yeah, I'd also recommend Men Speaking Freely. I found it really helpful. So I thought I'd give just kind of an update on where I am, just kind of a review maybe for men that don't know me. Well, I was a Gleason 9. November 2020, I had a prostatectomy. I had a biochemical recurrence a month, 6 weeks later. There was still PSA. So then I had 37 radiation treatments, 18 months of Firmagon. And then after that, I had a period of about 14 months of undetectable PSA. Earlier this year, my PSA showed 0.04. And then, another month or two, a month after, it was 0.35. And within the last month or so, it went up to 0.74. So it's basically like doubled in like a month or so. So I about 10 days ago, I had a Polarify scan, and the scan showed one metastases for sure that lit up brightly. The other, there's another possible metastases, and Dr. Chang, my GU medical oncologist, she wasn't quite sure about that one. But next week I'm going to meet with a radiation oncologist at Fred Hutch. So Dr. Chang, she put me on a regimen of Eligard. So I had a 3-month Lupron shot because that's what my insurance paid for. And then abiraterone, I'm on 100 milligrams a day now.
1,000.
Is it 1,000? Oh, sorry. And then 5 milligrams of prednisone. And I guess my question for the group is kind of 3 questions. Is this considered kind of like a normal standard of care for my situation? That's question 1. Question 2 is Dr. Chang didn't feel like it was important that I had the radiation right away. She said any time within several months, it would be appropriate to have the radiation. And then finally, like, are there any side effects with abiraterone? I mean, I've had the Firmagon, so I know about the hot flashes, but with that combination, are there any side effects to be aware of? I will be having blood tests every 2 weeks to kind of monitor, I think liver levels or something. So that was kind of my
What about
update.
the questionable lesion? You know,
Oh,
what,
that was the one.
but
I mentioned
questionable.
that. Yeah. So yeah, I guess those are my questions right now.
Okay. You can ask questions too, Mrs. B. It doesn't just have to be.
Well, I'll let Mark go ahead. He's he started, so.
Okay, well, jump in if you think he missed anything, okay? Feel free. We love having care partners in this group. Who would like to start? So there are two questions on the table. The first is about spot radiation. The second is about the doublet protocol. Peter? Go ahead, Peter.
Yeah, I did abiraterone for a year. I did not like it. For me, the side effect that troubled me most was brain fog. And I switched over to darolutamide, and I had a much better ride with that. I was on darolutamide for 2 or 3 years. It was much easier on me. But I know abiraterone is a standard, and it's the go-to thing for a lot of recurrence. But you might just keep that in mind.
Thanks.
Yeah,
One thing to be aware of, there's a
Hold on, Jeff.
major
Hold
blood
on.
pressure problem.
Hold on, Jeff. Len first, and then you.
Yeah.
Go ahead, Len.
I'll just echo what Peter just said. I had the same experience. I was on abiraterone. I had substantial fatigue and brain fog, and so I was switched to darolutamide, and it was much better.
Thanks.
Jeff?
Also, where was the metastatic site?
Oh, on my vertebrae.
A lumbar two,
Oh.
is it? The second lumbar vertebrae, L2, and then also a rib, questionable lesion.
Yeah.
But we don't know if that's for sure.
Yeah, they're always hesitant to call a rib metastasis a true lesion with PSMA, with the PSMA scans. There are a lot of false positives.
Oh, thank you.
Go ahead, Jeff.
I was on abiraterone for 2.5 years. I just stopped about a month and a half ago. I never had blood pressure problems. It raised my blood pressure quite a bit. You should get a machine and check yours, see what's going on. It also caused me AFib issues. I ended up in the hospital about 2 months ago for 4 days with AFib. Had four times I had it in a year and a half. And Abby just has heart issues. I've switched to darolutamide like other people have mentioned, and the problem is darolutamide. It's a very expensive medicine. It's over $10,000 a month, but there's a lot of discounts for people who are. If it's an economic problem, there's a lot of discounts. But the heart issues are really something to watch out for with Abby.
Thank you.
Wow.
Yeah, Gary?
Never got that warning.
I had 2 years of abiraterone along with the prednisone, and I think the prednisone did more of a number on me than the abiraterone. And one thing, since you're starting this protocol now, if you have not already had it done, would be to get a bone density scan, at least as a baseline to have, because the prednisone can certainly have an effect on your bones.
Thanks. Yeah, I do have osteoporosis, and I at least once a year I get a DEXA bone scan.
And you're on Lenderlite.
Yeah, and I'm on Fosmax Cylindrolite.
Okay. So a couple of things there. I'm glad you raised it because I wanted to say something to Dr. Jeff. So when I got diagnosed, it turned out I was osteoporotic, which was quite a surprise to me. At the time, because I didn't have any metastasis that they could see, they just gave me 3 shots 12 months apart of Zometa, zoledronic acid. Now, but this was back in 2007. For you, Mark, rather than that Fosamax, which is such a pain in the butt to take, I don't have to tell you, you should be able to get Prolia now, especially given the other, and the Prolia injections are, I think, every 6 months, and it's a lot easier. It's going to be a lot easier for you. The other thing that I wanted to say to Jeff and to you was that for me, the resistance exercise became even more important. And so I really tried to incorporate, especially putting stress on my spine. And it's difficult to come up with exercises, but you can do it. And over a period of 2 years, I improved from minus 2.5 to minus 0.9. And that was, now I've gotten older and it's gone back a little bit. I'm not on any meds now, but you really can make a difference with exercise. The exercise really can make a difference. It goes back to what Jimmy was saying before. It's another reason why, and Jeff, if you don't have one, look into getting a trainer who has a certification from the American College of Sports Medicine or comparable, because these trainers, they understand cancer and they understand the exercises to give you. And I get very concerned, just to take on a trainer who doesn't understand cancer can lead to some significant issues. So I really like the idea. I mean, if you've got a Y close to you, they may have a Livestrong program, and their trainers are trained for cancer. But if not, the ACSM does have a list of trainers. There's a really good lady in Jersey. I just lost her name. Carol Michaels in New Jersey, and she does a lot of video training now. But she knows her stuff. She's really good. So it's not just the medicines. Well, let's close out with Jim Marshall. Did you want to say something, Jim?
Yes. Did you actually start the pills yet?
Yeah.
Which pills?
You started the pills on Saturday, the abiraterone.
Oh, yeah. Yes. Yeah. I've only taken them like 3 days so far.
3 days now. Oh, okay. Because side effects wise, as I said, anyway, I was on it for 5 years, and I found out extreme aerobic exercise at times, okay, if I could, really helped. I mean, it was amazing. What else? Hypertension, you will have to watch it because, in fact, I was on the pills since 1994, so I had to adjust them.
Okay.
Other than that, anyway, potassium, you might want to get a test on that too. They don't generally give it, and there's a few other tests too.
Okay, thank you very much.
Okay, anything else, Mr. B?
Oh, I'm good. Thanks, Rick. Thanks, guys.
Okay, we hope to see you on Thursday. We can't invite you to that one, Kathy.
I'm
It's
going to come
men
to the
only.
women. I'm looking forward to the women speaking freely group. That's going to
Yes.
start.
Oh,
Yeah.
yeah. We are too. I just have to keep hounding Alexa to get it going, but she says she's got it and she says she's ready, and I don't argue with her. I've learned not to argue with her, so we'll be having with that women speaking freely will be coming soon.
Okay.
So okay, let's move along. Frank, you have sort of somewhat similar, but you've got a somewhat similar issue with spot radiation issues, right?
Well, the question is with my last trip to my doc, the CT scan showed that the two nodules in my lungs increased about 20% in size, and my PSA went from 0.12 to 0.18. Now, my doc immediately said, you have to understand, you're still dealing with very small numbers. But he said the trend he didn't like. So he set me up for a second biopsy. I had my first one 3 years ago because he wanted to check to see that the metastasis hadn't changed. And so I had the biopsy a week and a half ago. They went, my first biopsy, they went through my back, the needle biopsy. This one, they went through my chest. And they found after the biopsy that it was very much like the first biopsy after the analysis. They did send it off for a second genetic testing, just again to make sure of what's going on. After we're waiting for that, it should be back in a couple weeks. But my doc had considered radiation treatment for the two nodules in the lungs, but the radiation oncologist didn't like it. And he said that the one especially was too close to the heart. And they were talking about SBRT, but the radiation oncologist didn't like it. So he pulled away from that. And what he decided on was that he was keeping me on Orgovyx, but taking me off of darolutamide because he felt my metastasis was becoming castration resistant. So he took me off my second line of darolutamide, and he put me on abiraterone, 1,000 milligrams with 10 milligrams of prednisone a day. And I've been on that now for 4 days, and I go back in the first week of October. He wanted me on that for 5 weeks, and then he wants to do blood draw and testing after 5 weeks and see where the PSA is and if the new second line ADT had an impact on the cancer cells. If it doesn't, then he's probably going to set me up for a PSMA scan to see if there's any other hot spots in my body on what's causing the rise in PSA. So we're going through some steps to get to what will be the most effective treatment for the growth, and he's not above also recommending Pluvicto, and he's not above recommending a second round of chemo for me, but he wants to go through the process and see if the change in the with Abby and prednisone will have an impact on the cancer cells. I did get a second shot of Prolia. I started it 6 months ago, and I got my second shot on my last visit. So they're watching the bone density and making sure that's taken care of.
Frank,
So
this
that's
is John. Who's your oncologist?
He's Dr. Mortazavi at the Ohio State James Cancer Hospital.
Hmm. I mean, I don't know how other people are hearing this, but I'm hearing a person that's really staying on top of it, you know, really looking at all the angles, has backup plans, is not sitting back and saying, let's just see what happens. It just sounds good to me.
Yeah, my wife and I are very, very pleased with him and the him taking actions when he sees a change. But again, the first thing he did after the CT scan results came back, which of course I got in the email before I met with him. So I saw the results, and of course we came in pretty upset, and he settled things down pretty quickly by again that what I said at the beginning. He said, "Remember, you're still under a third of an inch in your nodules in your lungs. So understand the size, and also understand your PSA is still under 1." But he said, we're not going to sit back and wait and see what happens. I'm going to go through some additional testing. And then the second thing he did was to change up the second line ADT to see if that will change up the PSA readings.
Do you other guys agree with me that this sounds active and appropriate? And am I off here?
No, it is impressive. I just want to come back to the question you threw out to us when you by email about the SBRT versus HIFU. Where did that come from, Frank?
Well, it's actually the recommendation of HIFU came actually from Zero Cancer. One of the guys, I'm just on that on the Facebook, and I laid out the SBRT, and the person suggested that I look into HIFU, and the initial look into it didn't really show that it was feasible to use it because there's no history of it at this point in time. And but it was intriguing because you're using laser technology to zap the cancer cells. But it was a side item, not at the recommendation of Mortazavi, because he was pretty focused, if we could, to do SBRT.
Yeah, I mean, if it were me, I'd stick with SBRT. Okay. Well, I mean, you're on a trajectory. Let's see. Oh, Gary. Sorry, Gary. Go ahead.
What is HIFU?
High intensity frequency ultrasound.
Yeah.
Okay. And my other question for Frank was, what is the perceived advantage of going from darolutamide to abiraterone?
I think I've heard both on AnCan and other writings that I've researched, sometimes changing up your meds for the cancer cells disturbs the cancer cells, because I've been on Orgovyx and darolutamide for almost 2 years, and successfully. It's been successful, but he feels that there may be some advantage to changing up something for the cancer cells to be able to react to something different.
Understood. Thanks.
You know, and that's something we talk about quite a bit on here. It's controversial. We had somebody, you might remember, at the end of last session get very upset with us and hang up when we suggested that. But it's a valid suggestion. You know, you've been on abiraterone for 4 or 5 or 6 years. This guy had been on it for 7 years. You know, there's good reason, like this, like Dr. Mortasabi is doing, to change it up, because you don't want to get those cancer cells too used to the same treatment, because then they figure out a workaround and nothing works. And we've seen it, and it's scary. Right, Fratello?
I agree with everything you said, Rick.
Yeah.
I mean,
Yeah.
on the one hand, you're saying, I'm thinking, don't fix it if it ain't broke, but you
Yeah.
do have valid points about mixing it up, keep the cancer off balance. And I know I've heard that from Dr. O as well. So I guess
Yeah.
it's worth a try.
Peter.
Abiraterone is a good drug if you tolerate it well.
Yeah.
I've been on it. I was on enzalutamide for about 4 months, and I couldn't tolerate that. I was having dizzy spells and falls with it, and intestinal issues with it, and they switched me to darolutamide, and I had a much better reaction to it. I've been on Abby now and prednisone for almost a week, but I've seen virtually no change in my body, and no more brain fog like it's affected some. I haven't noticed that yet. Maybe it's too soon. Hot flashes remain about constant, fatigue about the same amount. So I haven't really picked up any difference in the side effects, which I had expected it was going to hit me a little bit harder, but it hasn't.
Right. So we got to keep moving here. I know I got a couple of guys who have their hands up. So let's take Peter as the last comment on this, and then we'll move on to the next one. Go ahead, Peter.
Yeah, Frank, I can understand a radiation oncologist's hesitancy to deal with lung near heart and so forth. You might want to look at the MRI real-time guided radiation SBRT. Look at the ViewRay website, because I think there is a place or two in Ohio or nearby in the Midwest there that has much more exacting machinery, where they might be able to zero in and keep an eye on any movement and shut down if there's anything any possibility of hurting something else.
I'll bring that up to my doc when I go in. I brought a lot to him from AnCan, and he's very open to questions and questioning different things that he's doing. So I'll bring that to his attention. The MRI guided SBRT.
Okay. So we got to move on, because we've got a lot of guys still to go yet. Let's go to John Kish. You had something on your mind, John.
Can you hear me?
Yes, we can
Yeah,
hear
I'm here.
you. Yeah.
Okay. I know somebody. I got the phone number for University of Penn and the Geno urinary guy down there, but I got a total body scan, the radioactive one, and then my stomach, chest, and abdomen, and there's not too much there, but I never brought it up at the National Institute of Health on my own. I enrolled in a clinical study, and they want to do, if my sister lives down there, but I'm going to try to get to there. They might take me in the study because I don't want to take Lupron again, and it might be like enzalutamide or apalutamide, or they said an immunotherapy. But I have other health issues, so they might not take me for it. But then I have genetic testing with Geisinger in December, and then I have a telephonic genetics they're going to ask with St. Luke's. So I know I'm complicating things, but I don't really want to take Lupron again. And but my doctor's kind of mad at me locally because I enrolled in that study on my own, but and they sent the records to the National Institute of Health, and they called me. I see my regular local oncologist tomorrow, but my sister with her computer and NIH kind of told me the results of both scans. So as far as I know, there's no metastases, and my aorta's enlarged, but it's been that way for about 2 years, but it's stable. So, yeah, I know I'm all over the place, but but doctors don't like when you get different opinions. I don't know. Okay, so that's about it.
So a couple of things. First of all, if doctors don't like you getting second opinions, they're not the right doctor. So
yeah, that's what I think it is.
Don't feel bad about that. If the doctor's upset with you because you ain't got a second opinion, you probably want to get the second opinion to be your first opinion, and then you can find a second opinion again. Secondly, where is your PSA? It was up to 1.86. Is that where it still is?
Yeah, they didn't recheck it. I see him tomorrow because I use a shuttle that you have to pay for because I don't have a car anymore, so I can't transportation's still a problem. The American Cancer Society said they might help me, but it's only for my cancer-related ones, and the NIH said they might help, but I have to get a hotel room down there if I go to the NIH, and I mentioned to NIH about rotating medicines, and they kind of got mad, so I know they're supposed to be good, but I guess there's only 1 or 2 medicines for the trial, if I get in it. And then,
okay, so look, I want to explain something to you because it's important you understand. I know that that you didn't do well on Lupron. All of these medicines, they might act a little differently, but they're all trying to do the same thing, which is to stop testosterone from getting to the cancer cells. And when that happens, that's when you have these side effects. So, we can talk about Orgovyx or Lupron or Firmagon or Zoladex. They're all pretty much going to have the same side effects. There may be some small tweaks, and, we like the Orgovyx better than the injections now from the guy's experience, but by and large, they're all going to do it. And same thing with the abiraterone or the enzalutamide or the darolutamide. They work in different ways, but they're all doing the same thing. So, but maybe for you, if they're doing a monotherapy trial just with enzalutamide or just with abiraterone, it might be a good idea to try it. The last thing I want to say to you is that if you need to get hotel rooms, the American Cancer Society has a a really good program, discount program with extended stay. And the NIH may even have something that they can offer you, but there are ways to do that. I think General Joel is the expert on that. But come in again next week when Joel's here, and we can have Joel call you. We'll try and get Joel to call you, and he can talk to you about how to get subsidies on if you need a hotel room.
Yeah, and I'm hoping when I see my local doctor that, if I don't get into that trial, because they have to do a physical down there for NIH, because I have a lot of other medical problems besides the cancer, so I might get disqualified. But if my local oncologist might want to try something else, I will. But then I had my prostate removed at University of Penn, so they still have my records there. So, then that's another backup. And I know they have the genitourinary doctors down there. So
yeah, and they're good, and they also have the genitourinary guy there, Dr. Narayan, Vivek Narayan, who we like a lot. He knows us well. He also is very big on the cardio stuff. So if you've got cardio issues, he would be a really good doctor for you.
yeah, I don't think because I was in a hospital. Well, actually, when I started at Lupron, and they checked my 3 months after Lupron, they checked my heart, and it was good then, like 24-hour whatever, that monitor when you're in the hospital. And it's I don't know what caused it, stress, age, whatever, bad diet, my prescriptions, but
Okay.
initially I didn't. When I started Lupron in July of 2020, there was nothing wrong with my heart, so that's a kind of a new
Okay.
issue, Yeah.
So,
Okay.
what you need to do for us is find out the number of that trial. There's going to be a number. It's called an NCT number, National
Okay.
Clinical Trials, and you want to find that NCT number. And if you and give it to Alan. You got Alan's telephone number. Give Alan that NCT number, and then we can start figuring out what that trial is and counsel you on the trial, John.
Yeah. Okay. So you said NCT number. Okay.
Yeah.
Yeah. I'll call NIH tomorrow, and then I'll get that trial, and then yeah. So I know my doctor isn't a genitourinary one, where I live. So I definitely want to get somebody that
Yeah, you got
specializes
to get somebody else. All right, I'm gonna keep
Okay.
moving along. And Alan Babcock, you're up next.
Right. So real quickly, I saw Dr. Gainesman, and it's 6 months out from when I stopped the ADT therapy, and my PSA continues to be undetectable. And he said, "Yeah, well, I'm not all impressed with that. I want to wait for a year because my testosterone went from 9 at the end of the ADT up to 420." And so he said the next year is going to be the biggest test of everything. He said, if you can make it through the next year, and he said there might be some minor fluctuations. Don't get freaked out if it becomes detectable and it's real low. He said, but if you keep it stays I didn't give me any number, but if he says if it stays low for the next year, then the cancer is not as aggressive as he thought it was 6 months ago. But he said, I'm not making you any promises, which shocked me because he usually is very optimistic. I guess he's getting to know me. So that's where I stand. It's like, okay, not on any treatment. He still wants to do the PSA every 3 months. So I know that he's concerned, because if he wasn't concerned, it would be 6 months. I didn't ask him that, but that's my take on it. But there I am, that it's like, okay, the next year is big time stuff. So there you go. I'd also real quickly at the end make another plea for men speaking freely, although I don't want the group to get too big.
Well, look, it's good to hear that you're undetectable. I mean, that's really good. And it's really good to hear that your PSA is back up to 420. When did you come off the Orgovyx? February?
Yeah, February. Yep.
And you're
Halfway through
70
February.
and you're 74, right?
Yeah, I am 74. Yep, pushing 75. Yeah. Hard to believe, but yeah.
So, Dr. Jeff, take a note. That's why we like Orgovyx. That's one of the reasons we really like Orgovyx. It just seems like with the Orgovyx, Joe Gallo's not with us today, but Joe was similar, 77, and his PSA came back, his testosterone came back really quickly. So, I mean, it's anecdotal, but we're seeing it more and more. And if you can get it, that's one of the reasons we'd like to see people ask for it. So, anybody have anything to say to Alan?
I have a question for Alan. It's Muslin. Hi, Alan.
Hi.
How are you feeling
Muslin.
Hey, I just called in. Everybody just left. How are you feeling emotionally, Alan?
I am feeling great. I mean, I feel better than I have even, from when this whole shebang started. I am feeling well emotionally. I am going to move down and become a live-in grandparent in a month or two. My house is up for sale, so I'm real excited about that. My wife is ecstatic. I'm feeling great emotionally. And I love Gainesman being honest with me and saying, listen, I'm not making any promise. We just have to wait and see. And he said, I'm not. I asked him, okay, what are your treatment options? He said, no, you're not going to get that out of me. Not till, I need to talk to you about it, because I don't think it's a good idea.
Good.
And I can live with that. I don't need to be researching.
Where are you moving to?
Springfield, down near Philadelphia.
Okay. Sorry,
So,
David. Go ahead.
Moving from a highly Republican area to a highly Democrat area, and that'll be a huge change for me, because Lancaster County is about as conservative as it comes, and I'm always butting heads with people.
David, go ahead, David.
No, it's just interesting to hear. And so you're totally drug. You're on holiday now, right, Alan?
On a holiday, yep. I'm not. Yep. I just take the vitamins and stuff, the supplements my wife gives me. That's it.
Yeah.
In fact, I'm off my blood pressure medicine.
Great.
You're the man. All right. Enjoy every moment.
Alan?
Yep.
Alan, I want to say one thing. You don't want to push speaking freely too hard, you say, but I have rehearsals on Thursday evenings for indefinitely now. So we're -1 on speaking freely. So go ahead and feel free to plug it, at least to somebody to take my place.
So just speaking freely gives us a chance to talk about whatever we want. And I know Rick says no, not treatment, but yeah, you can slip that in if you have to. You just not shut up. It just really is a nice give and take. When it's maybe 12, 15 people. So it's really, we get into some really great discussions. And one meeting and sometimes there's a topic that people want to bring up. And I don't want to keep talking, because I know there's a lot of people that want to talk. But I just love it. I mean, I think it's wonderful. I've rescheduled other meetings so that I can attend.
Okay, we gotta keep rolling here. Jeff Dreyer, Jeff D, what's on your mind?
Okay, good. So I met with Dr. Rahul Agarwal, and this was last week, Monday, and let me see, I had a PSMA PET scan set up for 2 days after that. So the brief history was my PSA has gone up from over the past year, 0.2 to 0.25 to 0.45 of this earlier in July. So I ordered the PSMA PET, and Dr. Agarwal agreed with that, of course. So what his little notes here says, his assessment: patient presented with localized prostate cancer by conventional imaging, high risk.
Hold on, Jeff.
Okay. Yeah.
Summarize it for us. Don't read. What did the PSMA say?
So the PSMA said that there are possible metastases, including L4, B iliac, and rib.
and something seen in the chest cavity as well, which is maybe an artifact. Some nodule, yeah. So anyway, 4 or greater osseous metastases. And so that was confirmed by a pelvic and a lumbar MRI last week. So that's where I am right now. What I'm going to meet with Dr. Agarwal in a couple of days again. And I think, well, he said he might consider referring me to radiation oncology for spot radiation, possibly for the lumbar metastasis. And then type and duration of ADT is what I suppose we'll be talking about. So this is all a huge shock to me, of course. I feel like I've fallen down the rabbit hole into a nightmare, and let's see, feeling scared and sad. And I guess I can't talk about that stuff here, but I feel like those probably aren't good things to help my condition. Maybe being scared is not a great mode of therapy, probably. So anyway, that's where I am right now.
So, Jeff, let me just say, you can talk about that stuff here. Of course you can. But the better place is Men Speaking Freely. That meeting's on Thursday, and so please come into that. And Dr. John and David are both here, and they're hearing you now, so they'll make time for you on Thursday. But of course you can talk about it here. It's really the other way around. We don't get into the details of treatment in the other meeting. But a couple of things come to my mind quickly. First of all, the report seems to say that there are probably 4 or more lesions, correct?
Yeah, iliac and lumbar. Yeah,
right.
Rib,
so
possibly.
I think the big question that I would be drilling down with Rahul, and say hello to him for me. Did you like him when you met him?
Yeah, sure. Yeah. We had a Zoom meeting, and I'd like to meet him in person, but yeah, he's
right.
Perfectly.
I mean, he's just a good caring doc, and I think you've got to decide whether he considers you to be oligometastatic, or whether he considers you to have high volume metastasis. Because
he mentioned he considered me oligometastatic based on the PET, the PSMA PET. Although the person reading the PSMA PET scan, the radiologist, flagged it as disseminated, but he differed, saying it's oligo in his opinion.
I would trust him, but the reason is because if you are more than oligometastatic, and usually that's 4 or 5 lesions, 5 at the max, then you could be a candidate right now for chemotherapy. And whilst that doesn't sound particularly attractive, it's very effective. And you could be, you could be a triplet candidate where they would do ADT plus second line and anti-androgen plus chemo, and we know that works. We know that the triplet therapy is a good option for recurrence in a situation like yours, and I think that is really going to be the meat of the discussion. If I were present and speaking to Rahul, that's really where I would be going. At the same time, I would definitely trust his judgment. Alan, you want to say something?
Yeah, Jeff, I want to remind you that things like being scared, being sad, being upset can be treated. We think, oh no, we can just treat disease. No, those feelings can be treated. And I would encourage you to seek somebody you can talk to about managing those feelings, because they can be managed. And when they're not managed, yeah, they're not very helpful to any of us.
Yeah. Okay. Yeah. Okay. What about spot radiations? Anyone have any comment on that? Effectiveness?
Who would like to take a shot at the effectiveness of spot radiation?
go.
No, I think I know who I want to talk on this. I'd really like Ben. Are you with us still? I guess not. So we had a little discussion this week with Alan Adele, Tall Alan, about spot radiation, because we actually tend to encourage discussions with your doctor about spot radiation. And Alan Adele came back and said to us, well, there's no evidence for it. And he was basically quoting a study from that was run between, I think, 1993 and 2000. I mean, just an ancient study. It was an old SWOG study. And we really do think that spot radiation for the right people works. So that's our take. Who was it who just wanted to come in on spot radiation?
David Muslin.
Well,
Please,
I was going to
David.
say,
Yes, I had two Mets on my ribs. Spot radiation at Northwestern in Chicago by a great, who I thought was a good radiation oncologist, and I went there for three visits, and they're gone. No pain. It was very simple. It was did it with my eyes closed more or less, and they're gone. So SBRT worked really well for Mets on my two ribs.
Thanks, David. Dr. Jack.
I had SBRT on my rib, and also I haven't gotten the results yet. I'm not sure how they're going to determine whether or not it worked, but it was certainly highly recommended by the people who I consulted, Peter Carroll and my medical oncologist and the radiation oncologist. So they believed in it. I'm assuming otherwise they wouldn't have recommended it so highly for my oligometastatic condition, which was on one rib, on one vertebrae pedicle, and on 3 pulmonary lymph nodes in my subcarinal area and in my right lung. I'll see the radiation oncologist next month, and I'll see what he has to say. But right now, I'm hoping it works. I don't know how they're going to determine if it does. I'd like to be educated to find out more about that.
Jeff, was the PSMA scan was done at UCSF, correct? You're muted.
Correct, at UCSF.
And it was read, and I'm assuming it was also read at UCSF then.
That's right.
So, that is, there's probably nowhere better in the country. There may be a couple of places that are as good as, but there's certainly nowhere better in the country. So, whoever's reading it, I think you can rely on what they're reading. And of course, Rahul knows how to read those scans too. He's got loads and loads of experience. So, because that's always a concern with us, always a concern that they haven't been read properly. But that's not true in your case. I would say this: you have every reason to feel emotionally how you do, but our job in this group is to kind of give you the support that you need to deal with it. And there are so many treatments out there today. You are, now that you're with Dr. Agarwal, you've got a great team. If you do need spot radiation, the radoncs at UCSF really know what they're doing. so you can trust them. And you know, this is now you managing the disease. You've just got to manage the
Yeah.
disease.
Well, yeah. I mean, I'm in a dark. I'm in the dark right now. Like I'm thinking, what do I have? 6 months? Do I have a year to wrap up my affairs? What's Well,
Okay, well,
I have no idea.
Peter Kafka, why don't you? How long have you had, man? And you're going strong.
9 years, and I've been through it all.
With metastatic for
Surgery,
9 years. Wow.
surgery, 2 kinds of radiation, on and off ADT for 8 years, chemotherapy, immunotherapy, you name it, and I'm still going. Mine keeps coming back. The cat keeps coming back. It was on the doorstep the very next day, but I'm not giving up. And
I love those guys.
truth be told, every one of us is scared as hell. Every one of us on this call is scared for ourselves, and we're scared for each other. But we're moving on. We're moving on. It's always wise to clean house, but don't start putting your affairs in order. You're not going to disappear on us. Don't worry.
All right,
You
good.
got a long
So
way to go.
I had a question for you. You said you switched to darolutamide for 2 to 3 years. Why did you stop after 2 to 3 years, or what happened then?
I went on to another. It wasn't working anymore, and I went on to immunotherapy.
So you got,
I didn't need
so
it.
you castrate resistant, or
Pretty much so, yeah.
Yeah.
Anyway, but don't. Fear is natural, but just keep moving one foot in front of another. The way we can manage this, you can go on for a long, long time.
All right. Yeah. Well, I
Okay.
like to exercise, so that's a good thing, I guess.
It is a good thing, and you'll keep coming back here. We'll keep guiding you, but there are plenty of guys. I've got to keep moving, guys, because we've still got 6 people that need time tonight.
Okay,
And,
thank you.
Okay. Jerry P.
Yes, sir. You've been talking about what I want to talk about, sort of on a more sideline issue. But here's the deal: my PSA in the last 2.5 months has doubled. So, interestingly enough, of course, the next step would be a PSMA scan. And after that, whatever we find, I would do SBRT on it just like I did before. But here's my question. How many times can you keep doing SBRT? I have lesions all up and down my spine. So, I'm going to get these little cats showing up quite frequently in a way. I was hoping not, but it seems like after 4.5 years, they're getting a little more excited. But the real question is, because I can't remember from my days in work, how much of the ream or rad, however you want to determine it, can a human body have? Because I'm feeling like I can't do the SBRTs as many times as I want. My mindset was aggressive to go and get it all every time it shows up. But then I got to think about, wait a minute, I don't want to end up at the end, whenever that is, and I can't use radiation because I've had too much.
Who wants to take a shot at how much radiation can you do?
Rick, I'll take a shot. I don't actually know if what the limit is in terms of radiation gray units.
Right.
But it seems to me that if you said you have lesions up and down your spine, they don't usually recommend spot radiation if you've got more than 3 to 5 lesions. And of
Why
course,
not?
I guess they just feel it's futile.
Yeah,
Why hit
it's
one
not
or two,
right.
lesions when there are a bunch of others that you won't be hitting? And of course, the concern is that you'll be depleting your bone marrow of infection-fighting cells.
I mean,
Red
is
blood cells,
somebody
white blood cells.
That
But
doesn't
then,
Jerry?
mean that doesn't mean they give up, Jerry. It just means that they they bypass the specific therapy in favor of a systemic therapy that goes all the way through your
Right.
body and gets, all the little spots that might otherwise show up later.
well, that's the other thing that we were starting to discuss was chemo, because I haven't had chemo.
Well, I think that in a situation like yours, I mean, you're thinking about spot radiation, but you're not a good candidate for spot radiation because you've got too many spots. And so you have to look at systemic. And if you haven't done chemo, you got to get it under your belt only because you become a candidate for another therapy for the Pluvicto, because right now you can't get Pluvicto. It's not approved unless you've gotten the chemo out of the way. So the stronger you are and the better you feel when you do the chemo, the better off it is. And to try and push that down, kick the bucket down the road with spot radiation, which really isn't going to do the job because there are too many spots. I mean, the conversation with Dr. Singh should be around when am I going to do my chemo? Especially if your PSA is increasing. What's the most recent PSA, Jerry?
0.41.
So I think that it's probably it's probably around that time. And what are you on right now? Darolutamide
Zytiga
and
or
Zytiga.
abiraterone, prednisone, and Eligard.
Okay. So, it's rising and you are probably in the center of the radar for doing some chemo.
Well,
And
the interesting thing is that I got a little upset with Singh. He came across as, well, kind of, so it's there. Let's wait until you're at 1.0. Well, I hate to wait. But you brought up something I didn't know is that, that's what I was thinking of. I've got so many spots. If I do spot radiation for every one, I'm going to go over my limit.
Yeah, but spot radiation isn't the right treatment. That's why we were sort of talking a little bit with Jeff Dreher just before. How many spots? If you have that many spots, as Dr. John correctly points out, you need systemic therapy. And hopefully we'll knock it right back. And let's do that sooner rather than later. And in your case, I'm sure that Dr. Singh can set up that for you locally, so you don't have to schlep up to Phoenix every time.
Well, no, my med-onc here, Dr. Bajaj, is really nice, really good,
right,
and pretty much will do anything I ask. And he's been talking to me about darolutamide for the last 6 months.
Well,
but I don't think that's appropriate right now.
Well, to switch maybe to darolutamide at the same time as starting the chemo, you could try that. That might even not be a bad thing at all. But certainly those options are on the table. Anyone else have anything they'd like to say to Jerry? Somebody who maybe has been in the situation you know, you're becoming castrate resistant, and you're a lot of spots. Anybody have that, identify with that on the call tonight?
The other thing locally, Dr. Bajaj mentioned, was he thought he could probably, now this I don't know why, but I guess it's just a first line darolutamide and docetaxel.
Yeah, I mean, that, you know, that's a fair combination. I think you've just got to see how you respond to the chemo, and there are adjustments with the chemo. You know, there are some docs who will give you cabazitaxel before the docetaxel. I don't know why they do it. It wasn't approved that way, but there are some docs who like cabazitaxel first. You know, unfortunately, it sounds like the time has come and you've got to get it out the way.
Yeah. Yeah, I know that I understand. It's, but you've given me a clearer picture, because that's what I was worried about. All the spots I've got on my spine, and if I can't radiate them all. I just know that from my experience. You can't do that. So, okay. So the next step, no matter what, is chemo, really. All right. I can do that.
Good man.
Now that I'm in Tucson, I'm not worried about that as much.
Right. Agreed.
Yeah. So that was my question. That's it. You can.
Thank you.
Thank you.
Okay. So we're going to move on to Al Latimer. You still with us, Mr. Latimer?
I am still here.
Okay.
The last time I was on, I was talking about how hard a time I was having weaning myself off of prednisone, and I had taken almost 2 months to wind down from it, and then I was still getting that feeling what I call the wall after that. But in the last couple of weeks, it seems to have faded, and I'm feeling much better. And we also talked about maybe starting some low dose prednisone again, which I have not done. Now I'm thinking I don't need to. And as a side benefit, because I'm feeling better, I feel more like exercising, so I'm exercising more and longer. So that's all good at the moment. And I have another PSA test next week. We'll see where all that goes. But that's my update.
That's a great update.
That's good.
Go ahead, Dr. John. Go ahead, please.
I was just going to say, finally.
Yes, finally. So
That's great. That's great.
I had my last chemo in early April, and it was until really mid-August that I was really having trouble with it. But it seems I'm hoping that's what the situation is, because the last couple of weeks I've been noticing I've been feeling better. So it's kind of a reverse vicious cycle now, because I'm feeling better, so I can exercise more, so I'm feeling better.
And what treatment are you actually on right now?
I'm doing Pluvicto. I had
yes,
a Pluvicto.
I know.
Go ahead.
Just Pluvicto?
Well, okay. So I have I have my standard testosterone suppression drugs. I'm doing the estrogen, and I'm doing I just had a brain fog. Anyway, one other drug. No, none of those. Damn it! I forgot. I can't say it. It'll come back to me in a couple of minutes, and I'll shout it out. But
enzalutamide.
Nope. No, none of those.
Okay. So, but you're doing estrogen you're doing the estrogen therapy rather than a patch. You're doing a patch right now.
I'm doing a patch. I've been doing the patch since my days with Dr. Myers.
Right.
That started in 2007,
and
Okay.
I don't have the hot flashes. I don't have my bone density actually improved once I started the estrogen. Um, so I know no one's doing it. I mean, you're kind of you're kind of on your own when you're doing it, especially now that I don't have Dr. Myers to look after me with it anymore. And Dr. Schultz just kind of shrugs. He said I would never recommend that, but he's letting me stay
Isn't
on it.
isn't Dr.
Um,
Wassersug on estrogen?
Yeah,
Yes.
he is for many
Yeah,
years.
you're not alone. You
well,
got the guy that wrote the book.
how many other people on AnCan are using estrogen instead of Lupron?
Well, certainly Dr. Wassersug, certainly Richard Wassersug.
Yes,
And
but he's
we've
the one
had a
from
couple,
he's the guy from Canada.
correct.
Yeah,
And we've had a couple of other people over the years. I'd have to go in and look, but I don't
It's
know who
not
we
easy
have
to
right
get, is it,
now.
Rick?
but it's been very effective in keeping the testosterone basically undetectable.
Right.
Um, and it's I don't know, it's worked well for me.
I understand it's not easy to get. Is that possible? Rick?
Um, I don't I don't think it's hard. I mean, you just
I
get
heard
you
it's not
just
easy to get.
Yeah,
the estrogen patch.
Yeah.
Um, my the oncologist gives me a script for it, and I order it from the pharmacy.
Right. Yeah,
It's
I don't think so, Jimmy. I think it's easy enough to get. It's a question of whether you want to use it or not.
you know whether you can get your doctor to agree to it. It's
Right.
um,
Yeah, a lot of
I
doctors don't want to give it. I know.
Right. Because the other issue around it, and again, maybe Dr. Jeff can talk to this a little bit, is that it possibly comes with more cardio issues than the LHRH.
well
Nope,
apparently
that's it.
apparently that's controversial. I mean I don't have cardio issues, so maybe I never did, so maybe I'm not a good person to talk to that. But
Right.
I have cardio issues from some of the other things I've done, but I don't think I've had it from the estrogen.
Any gynecomastia, Al?
Oh, okay. The good and the bad. The gyneplastia was horrible. I
Sorry to
ended up,
mention it.
pardon?
Sorry to mention it.
No, it's okay. 7 years ago, I had a double mastectomy, and I'm fine. I got rid of it, and I had a doctor that specialized in treating women that were transitioning to be men, and they called it top surgery. So
Oh,
I
man.
had top surgery, and it's worked out fine.
Yeah, double
I can go
mastectomy,
I can
Myers.
go to the beach again.
You're old school. I like that.
So
So
I think Dr. George has used it. I don't know if he still is, but George Sadier has used it. And there was one other gent who also happened to be a doc who used it. But
the doctor that lives in down your way, Rick, has been using it. Brain fog again. I forgot his name too.
Carlos?
Carlos, yes, Carlos.
Oh, Carlos used it? Okay.
He's used it.
Okay.
But he's used it. He's a doctor. He's self-prescribed.
Okay. Yeah, that's right. Because when we did a little group on it about a year or two ago, and he was involved in that group. So, all right, guys, I got to keep it's 7 o'clock, and we've still got 1, 2, 3, 4 people. So I'm going to stay on as long as it takes, and I encourage you to. And we'll get through everybody. But that's great news, Al.
Okay.
We're gonna go. So
Yeah,
let me.
Rick.
Yes.
Rick, the other drug is Avodart. It just came back to me.
Oh, Avodart. Okay. 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 Um, so we've got Jeff Wood, Jay, Jim, B, and Jimmy. So these are the last four people. So and I think most of these are updates. So except Jimmy, Jeff Wood, are you still with us?
Yeah, but I'll be back next week. Move on.
Are you sure?
Yeah.
Okay. So Peter Kafka, you'll make a note, right? Jeff Wood goes to the top of the line. Okay. Okay. Thank you. So Peter's got you. He's moderating next week, and we'll take you to the top of the line. Jay.
Just a quick update.
Yes,
I'm
sir.
on. Can you hear me?
Yes, sir.
Okay. I'm on Lupron injections and enzalutamide. I took a 2-week holiday from the enzalutamide because of dizziness, and I resumed on the enzalutamide instead of the 4 tablet or capsules. I'm taking 2. When I resumed, that's when the dizziness came back. So I'm meeting with my med onc on Thursday and see what he has to say about it. But it just kind of comes on me and just uh, makes me uncomfortably, not steady on my feet.
Mm-hmm.
So
Frank Fabish, are you still with us? Yes, you are. Turn on that mic. Talk to
Some
Jay.
on. Yes.
Talk to Jay.
Uh, say that again.
I said, talk to Jay. Jay's having trouble with enzalutamide and getting dizzy.
Okay. After my chemo, uh, my doc added, in addition to Orgovyx, he added a second line ADT of enzalutamide because the VA wouldn't approve darolutamide. And I used it for about 4 months, and I had 3 falls in 4 months and a lot of dizziness when I got up. And my oncologist suggested to move to darolutamide. And even though the VA wouldn't approve it, I applied to Pfizer and they agreed to send it to me at no cost. And I've been using it up to a week ago without any problems and no falls, no dizziness. Um, so yes, I understand the dizzy problem with enzalutamide.
okay, good. Thanks for
And
mentioning that.
the way you dealt with it was you switched to darolutamide, correct?
Correct. I couldn't do anything else with it, and the medical team couldn't do any more with the meds, and that's when they switched to darolutamide because they felt that I would have less side effects from it, uh, and hoping that it would the dizziness would go away, and it did.
So Jay, where you are down in Florida, you don't have a genitourinary medical oncologist.
I do.
Oh, you do?
Yes.
Okay.
In Orlando, I have Sampavde, Guru Sampavde.
So, what's his name again? Guru, Guru?
Yes.
And the last name, Sampavde?
Yes.
SAM?
SON PAVDE.
Sonpavde. Okay, and where is he? Is he a Florida Oncology or where is he?
Advent Health in Orlando.
Okay, well, yeah, let's. I'm sure one of my guys is looking him up as we speak. But if he is a GU medical oncologist, then you got to get together with him and you got to lean on him to try and get you darolutamide.
I'm seeing him on Thursday, so that's why I wanted to mention it today.
I mean, there's a very, very limited evidence that enzalutamide is related to possible stroke activity. But the incidence is really, really rare, but it is disclosed as a side effect. But we've never seen that, but we have heard about this dizziness before. So you're not alone. I don't know. Some of the guys may know more about blood pressure and enzalutamide and blood pressure. Is there anything that anybody knows about enzalutamide and blood pressure? Guess not.
I know that my blood pressure, I was on 2 different pills for blood pressure, and I had to eliminate one of them. And my blood pressure is usually maybe 100/68, in that range.
Mm-hmm. So, it may be that you've got to work with him a little bit. I'm just looking at his biography. He certainly has he's definitely a GU medical oncologist. That's the good, the good news. He directed the GU program at the University of Alabama, and he has a lot of experience in bladder cancer. So yeah, I mean he's a GU med onc, and but his field is really bladder cancer. But that's fine. He should be well versed, and so you should have a good appointment with him and see if you can get him to give you Darrow.
That's what I'm planning on doing. Good, thank you.
Okay. Anyone else have anything they want to say?
Could I ask a question about enzalutamide? How much of a cognitive risk for dementia risk? What do you guys think about that?
I don't think it's any more than any of the other second line anti-androgens. I don't know. Len, have you ever seen anything on dementia and second line anti-androgens?
Yes. No, I shouldn't say. What I meant to say is I believe that Alicia Morgans is running clinical trials to assess cognitive deficit in the second line anti-androgens.
Mm-hmm.
I forget the
Does
name
that
of the
seem
project.
that there's reduced cerebral blood flow and so on with enzalutamide versus darolutamide? So it's a
Well, we know that darolutamide should not cross the brain-blood barrier, the blood-brain barrier, whatever it is, and that's why, the guys who have been on darolutamide feel so much better on it. And we personally think, this is not medical advice, but we personally think, based on peer experience, that it is a much better drug if you can get it. It's just not the easiest drug to get. You've got to have a doctor who's willing to go to bat for you to get it.
yeah.
But Jay, I do think that that maybe a switch is going to do for you what it did for Frank Fabish.
Sure hope so.
Okay.
Thank you, guys and
Okay, we're
girls.
going to go to Jim Barnes.
Hey guys,
Hi, guy.
I had a terrible time on enzalutamide as well, and I had to move to abiraterone. But I went to enzalutamide first because of previous heart conditions. But and the abiraterone treated me much better than the enzalutamide. But the reason I wanted to talk tonight was 2 weeks ago we had talked about my completing Pluvicto, 6 rounds of Pluvicto, and my PSA was rising. I still had low testosterone. It appears to be there might be new lesions. So I have this disconcordance in test results. And we were talking about during the last call not only getting a PSMA test, which is scheduled for September 26th, my diagnostic scan after my PSMA, after my Pluvicto treatments, but in addition, asking them to do an FDG scan. And before I could get the words out of my mouth requesting that, they said, well, insurance won't cover both. And, it was a little frustrating to hear. But, the idea is we're going to want to do the FDG test to find out if there's any different types of cancers that we ought to be treating. Are we treating the right cancer now?
Right.
So, yeah, I understand all that, and I'm just looking for any arguments back on why it should be covered. And then also I want to touch on what Jack had to offer me last time was some blood tests, which was the NSE, the GGT, and the ALP tests, which are, I guess, blood markers for other types of cancers. So I'm just trying to figure out what's the best course of action. And, I kind of don't know what I don't know here. So just looking to get on better footing
Okay.
with the conversation.
So the first thing that I would say to you is who is telling you that they won't cover an FDG?
My doc, my GU oncologist, Appleman.
So I go back to Appleman and say, Dr. Appleman, I want you to apply for it. And I want you to say that the reason we want to see it is to make sure that I don't have PSMA lesions. Appleman's a smart guy. He knows that most of the studies have been carried on have had some sort of concordance measurements in it. And, when they shifted on, that they don't even want to do the paperwork. They shifted over, and yes, you can get FDG and PSMA if there's reason to believe that the PSMA is that the Pluvicto isn't covering everything. And how else are we going to know without doing it? And he's got to make that argument. Yes, Al Latimer, go ahead.
All I can say is I had both done at UCLA, and there was no issue with the insurance company that I know of whatsoever. They just did it. Didn't even think about it. But I had both.
Great. Right. I was so glad to see you get on, Al, because I wanted to hear your opinion on that because I knew you were in that same situation.
Now that was 2 years ago at this point. But yes, I did have both.
Okay. Anyone else? Anyone else is there anyone else who can contribute to this conversation? I mean, we just know how important the concordance is. I mean, I know Dr. E's ordering it all the time. At the same time, I know that General Joel had an issue and he was able to get the FDG through the VA or what have you, which obviously isn't an option for you, but it makes no sense to me. It never has that the payers aren't requiring both scans up front before they approve the Pluvicto. So Len, you have something.
Yes, I was going to recommend asking if they won't give you the FDG scan. I was going to recommend asking for an Axumin scan because Axumin utilizes a synthetic amino acid which is taken up by the cell just like any other amino acid, which is as we know, building blocks for protein. So, in other words, it's a metabolic scan, and it doesn't depend on PSMA presence or absence. So that could be used to check for concordance.
Would that show different types of cancers aside from adenocarcinoma?
I didn't hear that.
I said, would that show different cancer types aside from adenocarcinoma?
That's a great question.
Would that show like a small cell?
Yeah, I think possibly yes, because as I said, any cell that's growing, it needs nutrients, and Axumin, the scan is a synthetic amino acid that would be taken up by an actively growing cell.
Yeah. So, Len, if you had your choice, which one would you have? Would you have the FDG or the Axumin scan?
Well, I think the FDG scan was the standard they used in Australia for their approval of Pluvicto. So if you can get that, I would go with that.
Okay. Okay. And what about the blood markers Dr. Jack was talking about last week? The neurospecific NLAs and the GGT and the ALP and those sort of things. Are those valid markers in you guys' experiences to determine if I have other types of cancer, like some
Yeah,
sort
I
of
think that the DLL3 marker seems to be the most common that they see for neuroendocrine. I don't know how you would get someone to sequence for that. Do you, Rick?
No, I mean we've been trying to figure out if it's available in a commercial lab. I mean, I know that Memorial Sloan Kettering is definitely running it, and Dr. Appelman could call one of his buds at MSKCC and see what they suggest. But right now, we haven't found a way. We've asked for it, and we haven't found a way.
Okay.
According to the literature, at least what I read, the neurospecific NLAs, the GGT and the ALT are all blood tests, blood markers you can get from a standard laboratory. I mean, if you want to look a little more, you could also add a chromogranin A. If you're concerned about a neuroendocrine. The one you just mentioned, Len, I'm not familiar with at all.
The one I mentioned?
No, the DLL3. The DLL3 was recently presented by Mike Morris and one of his colleagues in the in a seminar that included the folks at Peter Mac in Australia, and that's where we heard about it. But I think Dr. Jack's suggestion, the chromogranin, is pretty much a standard. But I think, I mean, I'm disappointed with Dr. Appelman that he's giving you a hard time over getting an FDG. I mean,
yeah. But he concurred. He said it's a valid point. He said you're not wrong.
But then he's got to fight that with then he's got to fight that for you.
I agree. That's very helpful. Thank you.
I'm sorry that and keep us posted.
No, I mean, this knowledge gives me confidence. I can go talk to him and get them to do what I need them to do. So, but I want to be on sound footing. So now I feel much better.
Yeah.
Thank you.
Yeah. I mean, there are docs doing it. There are GU medocs who are doing it around the country, and they know they're supposed to do it, and the good ones are doing it up front. But that's where we are. And for Jeff, Len just put a really good note on a Kareem Fasazi piece of research in the chat window. So
Great.
we're gonna close out with Jimmy.
Thank you, guys.
And Jimmy's got an old story that's come back to life again.
Let's not do it tonight, Rick. It's overtime, and I can come next week with this.
Yes, you can.
I
Okay,
may,
we'll
I may
just
die, and it's, it'll be your fault. But other than that, it should be okay.
thanks, Jimmy.
All right. Let's go.
Okay. All right. So we want you all here next week, so especially the docs, because we got to brainstorm Jimmy's fevers. Jimmy's fevers have come back, and we don't know why, and we got to figure out. So, Peter, put Jimmy on early so we can try and figure out his Jimmy's fevers. Okay. Jimmy, did you want to say anything about Jimmy Buffett before we leave on the record?
Jimmy Buffett on the record. Jimmy Buffett is an interesting guy. He made a lot out of what might have been a very, very humble singer-songwriter career. He was an incredible businessman, and he had some good songs. And more than anything else, he was just a cool, relaxed guy. When anybody might think of his musical skills or his songwriting or his artistic merit, the guy was just a lot of fun to be around, I'm sure. That's all I have to say.
Rick, one other thing about Jimmy Buffett. He died of Merkel cell carcinoma.
He did.
I am a Merkel cell survivor.
Oh,
and
wow. Okay.
That really kind of shook me that that outcomes can be so different. It's been 11 years now since I was diagnosed.
Al Latimer, you lived through everything, man.
I've had 4 different kinds of cancer.
Oh,
I'm
come back every week.
I'm
Al,
the cancer
were you treated
man.
out in Washington? Were you treated out in Washington
See,
by that?
the only one I
expert?
can't beat is prostate.
Yeah,
Okay.
still beating it.
I
Dr.
wouldn't
Jack,
bet against that.
No, I just wonder if the Dr. Nyan treated you out in Washington at the Fred
He did.
Hutchinson.
Yes,
He
Dr.
did.
Diem treated me. Yes.
That's probably why you're alive. I mean, phenomenal. He's saved several friends of mine. He's amazing.
Apparently, Jimmy Buffett did not go there.
No.
Because his website was asking for donations to Dana-Farber. So,
Yeah.
but they're no slouch either. I mean, these guys consult all the time. But yes, the Mecca is Seattle. I spent a whole summer in Seattle in 2012 being treated for it.
Congratulations. Thank you. Good night.
Yeah,
good night. Okay, everybody. We'll see you next Tuesday. Good night. Good night, all. Happy Labor Day. What's left of it. Goodbye.
Bye, everybody. Bye.
Bye. Come on in on Thursday.